exciting session today about really things clinicians really need to know about services we offer, as well as updates to the most recent guidelines for contraception as well as sexual health. If you've never heard the words doxy-PEP or doxycycline post-exposure prophylaxis, this is the place. If you've never heard the words Prep for Illinois or free HIV pre-exposure prophylaxis, this is the place to be. And we have an exciting group of panelists today with Dr. Quinlan, our Women's Health Medical Advisor, Dr. McNulty, as well as Dr. Trotter, and we'll go into introductions in a second. This session is being recorded, so please be aware, and we will send out the slides for this early next week. So on to you, Dr. Quinlan.
Okay, thanks everyone for joining. As Arthi mentioned, we're going to talk about sort of the intersection of public health and sexual wellness for healthcare providers. As she mentioned, there's CMEs available, hooray. That info for how to do that will be at the end. No disclosures for the speakers. The learning objectives are reviewing what's new in contraception this year. The CDC guidelines changed, so we'll go over that. Increase awareness of doxy-PEP, specifically for clinicians, and then discussion of HIV PrEP for use in the clinical setting. And then we'll close with IDPH resources that are really specific to clinical providers on sexual health, family planning, STIs, including perinatal syphilis resources. So presentations, this is me. I am an OBGYN, long in clinical practice in mainly Chicago, and for the last year and a half or so have also been the Women's Health Medical Advisor for IDPH. And the first time ever, probably two Mauras are presenting. Maura McNulty will be presenting about doxy-PEP. She's in the Division of Infectious Diseases at University of Chicago. And then Andrew Trotter, who is also in infectious disease at the University of Illinois in Chicago. So these will be the presenters for today. So let's start by talking about what's new in contraception. For those of you who care for pregnancy-capable folks, you will know that MEC came out with some changes in the summer, and I'll go through kind of really specific clinical what's different for us, and then we'll talk about the standing order that has been a little over a year that allows Illinois pharmacists to dispense hormonal contraception under a standing order from the IDPH director. So to start off, the CDC contraceptive guidance was released. So we know those of us, again, who do this know the MEC, which is the medical eligibility criteria. What we usually typically call it the MEC, it's when to use a method. The SPR is also from the CDC, and it is how to use a method. So most of us have the app, charts posted in our clinic. So updates, they released updates in August of 2024. And in the updates, I think we all were spoiled by when CDC changed their STI treatment guidelines. They, I see people saying they can't see the slides, and some can, but I'm going to proceed since some can. When the MEC updates were introduced in the summer, they gave this list of the criteria, the medical conditions that had changes in contraceptive updates, without really details of what the changes were. So it said postpartum, but what about postpartum? So I'm going to go through some specifics. They didn't do we have to have a track changes so we can see what about postpartum has changed. So to review the MEC categories, category 1 through 4, every method of contraception and the medical condition you're looking up puts it in a criteria. Category 1 is when there's no restriction to that method. Category 2 is the advantages generally outweigh the risks. Category 3 and 4 are concerning. 3 is where the risks likely outweigh the benefits, and 4 is a method of contraception that is unacceptable due to the health risks. So the biggest change, when you kind of drill down and go through the details, the biggest change in these guidelines are about Depo-Provera. Depomedroxyprogesterone acetate, so it's referred to as DMPA, but most of us at the bedside call it Depo-Provera or Depo. So this was a pretty big change, that there's an increased MEC risk category for Depo, especially with conditions that we know increase the risk of VTE, and I'll talk more about that in a second. They also changed the risk when someone is on anticoagulation, if they're on prophylactic versus therapeutic, which I think we've all known at the bedside. Isn't this person's risk different for clots when they're on therapeutic anticoagulation? So now that is addressed. So this is a table. It's kind of busy, but it shows the risk of hormonal contraception risk compared with the general population. The first column is the method, then VTE, venous thromboembolic event, ischemic stroke, and MI. Looking at the top part of the table is estrogen-containing methods. The bottom are progestins. And you can see Depo. So the top, we all know that estrogen increases the risk. Although when I saw this, I kind of don't think I fully realized how much worse the patch is. Again, the baseline risk of this is extremely low in our patient population. So it is still extremely low with this increased risk, but that risk is significant. But if you look down at Depo, the risk of VTE with Depo-Provera, that I think most of us have always sort of considered Depo as really safe for almost all users with very few contraindications, but CDC really identified this increased risk of Depo when compared to other progestins, and it's reflected in the new MEC. So this is the CDC slide. I want to call them out. It's fine. It's just pretty busy, and when you look at it a lot, it starts to make more sense. This is progestins and thrombosis, that new understanding and what it's meant for the guidelines. So the left column is changes in the new guidelines that reflect less concern about safety. The right is changes that are more concerned about safety. So on the left, things like lupus, cirrhosis, it gives the condition, and then in parentheses is the method. So lupus, things like progestin IUD, implant progestin only pills, that went from a 3 to 4 category to a 1 to 2. On the right, if you're looking at Depo only, things like someone with sickle cell disease, a history of DVT on only prophylactic anticoagulation, what Depo went from 1 to 2 to 3. So that's really different. So this is their overall, this page is all of their changes. It's busy as heck, but I think it's helpful. Again, the left column are changes in the new MEC that show less concern about safety. The right is more concern. So the less concern, again, things like lupus, regardless of the known antibodies, the IUD implant, those progestin methods compared to Depo. In the bottom, this is surprising, someone who's had a history of a DVT or a PE who's on therapeutic anticoagulation, we would think estrogen-containing pills are clearly not acceptable, but they've gone to a category 3 because of the therapeutic dose of anticoagulation. On the bottom right, the more concern about safety is primarily clot risk, conditions with increased risk of DVT or VTE. Depo has now a slightly increased risk. So the main change in practice relates to Depo. Okay, so another one that was a big change is sickle cell disease. So because of the risk of clotting with sickle cell disease, this I've just put them side by side. The top is the old MEC for sickle cell disease. The bottom is the 2024, the new one from this summer. And you can see CHC's combined hormonal contraception, anything containing estrogen has gone from a 2 to a 4, which is massive. So the other thing, I don't know that I ever really noticed this, but kidney disease was not anywhere in the MEC. So now chronic kidney disease is a new category where you can look up methods. They do this pink red tie-dye look over on the side that Progestin-only pills, drospirenone can affect potassium. So if the drospirenone containing progestin-only pill is a different category risk because of the hyperkalemia. So to turn to SPR, as I mentioned, is not when to use it, but how to use a method. And there's really 3 changes in the new one. The first change is to remember that folks using testosterone for gender affirming care need to be aware that that is not going to prevent pregnancy, likely won't, and that contraceptive counseling needs to happen. And then the hope is that we all make available and encourage use of self-administered Depo-Provera as an option for appropriate patients. The third updated recommendation in the SPR, I don't know if it's related to the massive amounts of social media with folks talking about the pain they had on IUD placement. But the third recommendation is really kind of common clinical sense, I think, that a person-centered plan for IUD placement and pain management should be made based on patient preference. So kind of the way of like, this will be fine, let's just do it, should be replaced by, it can be painful, let's talk about your options. And then if you look on the site, they give specifics about research on what lidocaine works the best, paracervical or topical. And then the data shows to only use misoprostol pre-treatment for those who have had a failure likely to a bit of cervical stenosis. So I'm going to go more quickly. The SPR has some really great tables that are in one place that talk about, they kind of put methods together. This is a table about when to start and how long to use backup, kind of nice for learners, or put on the wall for triage teams. This is amazing. We put this up all over at Stroger. In one place, it says recommendations for what to do with bleeding irregularities, all on one place, what to do with Nexplanon bleeding, etc., doses included. What to do with late pills, progestin-only pills, including separation for drospirenone, which we know is a little more forgiving. And then this is new too, the standard teaching was if someone had an IUD and had PID, diagnosed, the IUD needed to come out. The new guidelines are if the person wants to continue the IUD, you can wait and check them in a couple of days, see if their symptoms are better. So busy as heck slide. This is, they have made a wall chart of all that. This is everything I talked about all together. It's also available on their website, and you'll all get these slides, so the QR codes will come. And the app, everything has an app, and this one's really good. You can kind of scroll through when you're at the bedside. The other thing I just want to mention, many of you may know about this, that a year ago, May, a bill was signed into law that allows pharmacists to dispense contraception, hormonal contraception, under a standing order of the director of IDPH. So 30 other states in our country have the ability for pharmacists to either dispense or actually prescribe, someone come to the counter, talk to the pharmacist, and get hormonal contraception. So we are in the majority of states who do this. It's any hormonal method, pill, patch, ring, or injectable. And pharmacists need to complete an accredited training, and then the patients complete a self-screening based on the MEC. And this QR code, again, when you get the slides, goes to the IDFPR, the professional regulation website, with more details. So I am going to stop sharing my slides, and we'll hear from Dr. McNulty and DoxyPEP.
Great. Thank you, Dr. Quinlan. So I believe that Dr. Barnes is going to share here. Okay, great. Thank you so much. Okay, so I'm so excited to be here today to talk about DoxyPEP. No, I have no disclosures. Next slide, please. So we're going to talk about the evidence and the new CDC guidelines that support the use of DoxyPEP. We're going to review DoxyPEP indications, prescribing recommendations, and some other considerations, and then also discuss shared decision-making approaches for DoxyPEP. Next slide, please. So I think we all know that there are, high rates of STIs in the US, with an estimated 1 in 5 people having had an STI. Illinois actually ranks 10th in the nation for chlamydia cases, 13th for gonorrhea, and there may be updated numbers from these, and then 19th in the nation for primary and secondary syphilis cases. So we have a really strong need here to use methods that are going to help prevent STIs. Next slide, please. There has been a very recent CDC report that came out that has showed some slowing of the rate of growth of STIs and STI transmission. Gonorrhea cases dropped for a second year, so they declined 7%. Syphilis cases increased by 1% after many years of double-digit increases. And we have also seen a slowing in congenital syphilis. So our STI problems don't just impact the adults, adolescents and adults, but also our babies too, because we've seen big increases in congenital syphilis over the years. In addition, despite there being some slowing down of the rate of STI transmission, there are still disparities. So still some geographic areas and populations are affected more severely, so including Black African American, Hispanic, Latino people, as well as gay and bisexual men and younger people in general too. Next slide, please. So one novel tool that is really promising to combat these high STI rates is doxycycline post-exposure prophylaxis, or doxy-PEP. So doxy-PEP is the use of the antibiotic doxycycline after sex to reduce bacterial STI, or sexually transmitted infection, transmission. This is a patient-managed biomedical STI prevention strategy. And many of you have, heard about it. Some of you might be prescribing, but hopefully through this talk and the next few slides, we can kind of level the playing field. And just to mention that there are several really fantastic IDPH resources for this. One is a doxy-PEP fact sheet, which is linked to the bottom of the slides, and the other is a clinician letter, and I'll be drawing on those as we go through these slides as well. So doxy-PEP actually has been really shown great promise in reducing sexually transmitted infections, particularly chlamydia and syphilis, where it's been shown to reduce by up to 70%, and gonococcal infections by approximately 50%. So it's a really big reduction in STI transmissions using doxy-PEP. Next slide, please. One of the biggest studies that's been done to date was among MSM and transgender women, so men who have sex with men, MSM, and transgender women with HIV or who are on PrEP. And the combined incidence of gonorrhea, chlamydia, and syphilis was lowered by 2/3 with doxy-PEP versus standard care. This was a study out of University of California in San Francisco and University of Washington. Next slide, please. So based on, let's see. Oh, so I'm sorry, one of the images isn't appearing, but this should have, maybe hit one more time, please. Let's see if that helps. There, thank you. Okay. So based on this newer data that's come out, actually back in 2022, San Francisco was the first Department of Public Health in the US to release guidelines for doxy-PEP use. And since then, with this large trial at UCSF and University of Washington showing these great reductions in syphilis, chlamydia, and to a lesser extent gonorrhea, this prompted the CDC to release national guidelines, in addition to several other studies and additional data that had come out in support of using doxy-PEP. So the CDC released their guidelines in 2024, so this year, and the guidelines state that MSM and transgender women with a bacterial STI, so syphilis, chlamydia, or gonorrhea, that's been diagnosed in the past 12 months should receive counseling on doxy-PEP, so doxycycline post-exposure prophylaxis. They should be offered a prescription for doxycycline to be taken as a single dose of 200 milligrams that is self-administered, ideally within 24 hours and no later than 72 hours after having oral, vaginal, or anal sex. Patients should not exceed a maximum dose of 200 milligrams every 24 hours. Next slide, please. So what about other populations? So populations other than MSM and transgender women. So these other populations could include cisgender women, cisgender heterosexual men, transgender men, and other queer non-binary persons who have been assigned female at birth. Well, there was a study in a trial in Kenya with cisgender women that showed no difference in STI rates. However, the adherence in that study was very, very low. So while the pharmacokinetics of doxycycline and experience in treating bacterial STIs in these populations suggests that doxypep really should be effective, the clinical data at this point are limited. But it is recommended to use shared decision making to inform the use of doxypep with populations that are not part of the CDC recommendations, but who may be at heightened risk of STIs. Next slide, please. And so, given those high rates of STIs in Illinois and the concern about a really large increase in congenital syphilis, IDPH and in addition, the CDC guidelines, IDPH released a clinician letter in September of 2024. So in addition to recommending doxypep for MSM and transgender women who have had at least one bacterial STI in the past 12 months, and again, doxypep can be used by people taking HIV PrEP or by people who are on HIV treatment as well. In addition to that, IDPH has recommended offering doxypep using shared decision making to all non-pregnant individuals at increased risk for bacterial STIs and to those requesting doxypep, even if these individuals have not been previously diagnosed with an STI or have not disclosed some sort of risk status. And further, doxypep should really be offered as part of a comprehensive sexual health counseling and education program, really to all sexually active individuals. And that we're going to talk a little bit more in a future slide about what comprehensive sexual health looks like and what that should include. But some of the things are listed here. So HIV and STI screening, HIV pre-exposure prophylaxis and HIV post-exposure prophylaxis, appropriate vaccination, expedited partner therapy, and also contraception when indicated. Next slide, please. Okay, so how about shared decision-making for doxypep? So shared decision-making is a collaborative process where patients and their healthcare providers work together to make healthcare decisions. So shared decision-making for doxypep should really occur with all patients. So discussion of the potential harms and benefits of doxypep, including, side effects, what we know about antimicrobial resistance, which is really still under study, guidance on actions that they can take to mitigate potential side effects, and we'll talk about some of those, how to take doxypep. So, the when to take it, what the dose is, things like that. And then potential drug-drug interactions, including that patients shouldn't be taking it within 2 hours of dairy products, antacids, and other supplements that contain things like calcium, iron, magnesium, because of a drug interaction there that can reduce absorption of doxycycline. So really, in addition to discussing those risks and benefits and possible side effects, really talking to the patient about how doxypep fits in with their health priorities and other prevention strategies that they may be using. And then further, for shared decision making for doxypep with individuals who are cisgender women, transgender men, and others assigned female at birth, you have additional things to consider there. So that's things like talking to patients about their pregnancy status and desires, and also talking about contraception, I think is going to be a really important piece there. And then in addition, of course, with everybody, sexual behavior, STI history, HIV PrEP use and indications for PrEP use, those will all be considerations and talking about kind of overall sexual health. Next slide, please. So how does doxypep fit in with comprehensive sexual health services? So for anyone who's considering doxypep or starting doxypep, it is recommended to screen and treat sexually transmitted infections. Those include the bacterial sexually transmitted infections and also viral infections such as hepatitis and HIV. You also want to discuss and facilitate access to HIV PrEP for people who are not on PrEP and who are not living with HIV and who may have ongoing HIV exposure. And then also discuss other prevention strategies. So these are things like, again, condoms, and then we mentioned some of the others. So HIV PrEP treatment, vaccinations, and linkage to any other health and social services that may be indicated. Next slide, please. And this is just a plug that when we're talking about screening for sexually transmitted infections, particularly chlamydia and gonorrhea, these can be missed if we're just screening in the urine. So this was from a study of MSM in San Francisco, and you can see on the left that 77% of chlamydia infections were missed and 95% of gonorrhea infections were missed if there was no rectal and throat screening. And again, this depends on patient sexual behaviors, but if patients are having sex in any of those places, then those places should be screened for STIs as well in order to identify those infections and appropriately treat. Next slide, please. Okay, so what are some prescribing considerations? So before starting DaxiPep, it's recommended to review the patient's health history, current medications, including over-the-counter medications, allergies, and really just ensure that there are no health concerns, drug-drug interactions, or medication allergies. It is worthwhile to note that it's not recommended to take doxycycline as DaxiPep when you're using doxycycline for other reasons, such as prevention of other conditions like acne, rosacea, or malaria prophylaxis. It is also helpful to note that there are no significant drug-drug interactions that we're aware of between doxycycline and the antiretrovirals that are used to treat or prevent HIV, so for PrEP or for HIV treatment. And there are also no known drug interactions between doxycycline and gender-affirming hormone therapies. There's no doxycycline dose adjustments that are needed for patients with renal dysfunction, but it is helpful, again, to remember that doxycycline is generally contraindicated in pregnancy because of potential adverse effects on the fetus. Next slide, please. Thank you. Okay, so some other prescribing considerations. So just to know the available formulations. So there is a delayed release and then immediate release versions. The delayed release is doxycycline hyclate, which is a 200 milligram oral tablet. The immediate release are doxycycline hyclate or monohydrate, and these are 100 milligram oral capsules or tablets. And so for DaxiPep, a patient would take 2 capsules or tablets together for a total of 200 milligrams. The immediate release formulations are really more widely available and usually cost quite a bit less than the delayed release formulation. So that's typically what, what's going to be available to patients. Doxycycline is also covered by 340B programs when those are available. And it's generally recommended to provide enough doses to last until the next follow-up, and that's going to depend on, individual sexual frequency. That could mean that you're going to be providing a 90-day supply, again, depending on sexual frequency, or in some cases it might be 6 months, depending on what's going on and the decisions around frequency of follow-up, which is recommended to be every 3 to 6 months. You also have suggested billing codes here, which I think can be helpful. So STI contact or exposure, STI screening, other sex counseling, and then contact to unspecified communicable disease. Next slide, please. So what are some of the adverse effects and mitigation of these? So really common are GI side effects. So taking with food can help alleviate this. Esophageal injury and irritation can also occur. So it's recommended to take with an 8-ounce glass of water and remain upright for 30 to 60 minutes following a dose. And then other things to counsel on, so skin photosensitivity, using sunscreen, avoiding too much sun exposure and tanning beds. And then rare but serious is intracranial hypertension. So recommend to let patients know if they experience refractory headaches or visual changes to let the clinician know promptly. And then antimicrobial resistance is really still being studied in terms of how this can disrupt the microbiome, but it is reasonable to let patients, to make patients aware of that. Next slide, please. Okay, so some other pieces of important patient education. So one is just that, again, DaxiPep does not protect against HIV. And it's also not 100% protective against STIs. So again, having it part of a comprehensive sexual wellness program, including discussions about HIV PrEP for those who may be exposed. And then just letting patients know too about, how to take DoxyPep. I love this little infographic from Howard Brown Health. It's just 3, 2, 1. So within 3 days, take 2 tabs. Again, if it's the immediate release, and then just 1 time. So take 1 dose. And then also how to minimize side effects will be really important for patients to be aware of, for them to be kind of successful in taking DoxyPep and not needing to stop it, hopefully. Next slide, please. Okay, so how about follow-up and monitoring? So if a patient's on PrEP, you're certainly going to need to, the CDC recommendations are every 3-month follow-up. But follow-up visits should generally be every 3 to 6 months. You're going to want to screen for STIs, so gonorrhea and chlamydia, all sites of exposure, screening for syphilis and HIV. You should treat incident STIs per the CDC treatment guidelines. There's no differences. And if a person has been exposed to syphilis within the prior 90 days, you can test and treat empirically regardless of their DoxyPep use. And similarly, if exposed to gonorrhea or chlamydia and it's a known exposure, a highly suspicious exposure, you can offer testing and then treat if positive, or you can treat empirically. That is fine as well. Again, offering HIV PrEP or HIV treatment is needed, assessing side effects, ongoing DoxyPep needs, and continuing that shared decision-making conversation about it. If you are using in persons of childbearing potential, assessing pregnancy status. And then the doxycycline package insert does advise periodic monitoring of hepatic function, renal function, and a CBC with prolonged therapy. It's not totally clear, what to do with very intermittent use. So that might be a decision that you have to make based on how frequently a patient is using it, and also, comfort levels with, with yourself with monitoring that. Next slide, please. So in conclusions, DoxyPep is a promising new strategy for reducing STI transmission. We have some studies that are ongoing with DoxyPep, and patients are really excited about it, and they're eager to learn about it, and they're eager to try it. And we have some really great resources in the CDC guidelines, IDPH clinician letter, and the IDPH fact sheet, which are linked here. So thank you. Thank you for your time. And on the next slide, you can also see my email address if anyone would like to reach out.
That was fantastic. Thank you so much, Dr. McNulty. Now I will share Dr. Trotter's slides. Sorry. Wait, sorry. Wrong ones. Hang on 1 second. There we go. Can you all see those? Okay. You can see that.
Great. Thank you. So I'm going to just preface this with 2 things. One is that I'm sorry if whoever's advancing the slides, I think it's you, Maura. I have a lot of animation stuff, so I was thinking I was going to have to do that. So we'll get through all the different things that are going to go through with the slides. The other thing is this is a huge topic, so it's very hard to be very comprehensive in only 15 minutes. But I wanted to kind of give an overview of the landscape of HIV PrEP and give some information about newer agents, the challenges, and kind of comparing and contrasting them, because previously we really only had 1 or 2 options, and now we're getting more options. And I think understanding how to provide options to patients is really important so that they can choose which ones are right for them. But we also need to be comfortable with, how do we present them to our patients and communities, and what are the pluses and pros and cons of them. So next slide. And I just get some funding for research and service through Gilead through my institution. Next slide. So one of the things that's really important about HIV PrEP, and why I often take every opportunity to talk about it, is that there's still a lot of issues with access to PrEP. And particularly in certain populations. And this is data looking at the PrEP to need ratio, which basically looks at how many PrEP users are there in a group compared to how many people are becoming HIV positive in that group. And obviously we want more PrEP users to be preventing those infections. And what you can see on the right-hand side, particularly, is that in white individuals in the United States, the PrEP to need ratio has really increased well as PrEP has been used more, but in Black and African American individuals and Hispanic and Latinx individuals, it really has lagged. And so we really see these continued disparities even now. Although our science is improving and options are improving, we're still not getting access to the people who need it. Next slide. And then this slide is just a different way of looking at this. And specifically in Black and African American individuals, they only represented 14% of PrEP users in 2022, but accounted for 40% of new HIV diagnoses. So there's really this disparity between the access and use of PrEP and the profile of people that are becoming HIV positive across the country. And that's mirrored also in Illinois and in other locations. Next slide. So what does PrEP look like now in 2024? So we have daily oral PrEP, and so there's two options. One is TDF and FTC, or tenofovir and emtricitabine, or known as a combined name of Truvada. And then also we have Descovy. You have to click again, which is the other daily option, which is a different formulation of tenofovir, also with emtricitabine, and is the brand name of Descovy, as I mentioned. So these are pills that you would take every day. So it's daily oral PrEP. Next. And one of the other interesting ways to use PrEP is what's called 211 or on-demand PrEP, where an individual takes the PrEP when they need it. So it's kind of similar in a way to Doxy PEP, but it's before, so it's PrEP, but it's as needed. And a lot of people really like this because they can use it when they need to. It's only been studied with Truvada, so not with Descovy. And the way it's taken is you take it within 2 pills within 2 hours before, at least 2 hours or less before sex. And then you take 1 pill after 24 hours and then 1 pill after 48 hours. And then you can keep taking it after that if you need to, and then you essentially are on daily PrEP. But people like it because if there's like intermittent need, but people want to be, have PrEP coverage, then they can use it when they need to. Next. And then now the kind of big new thing is injectable PrEP, so long acting. And currently what's available is cabotegravir, or known by the brand name of Apretude. This is a long acting injectable. It's in the class of integrase inhibitors. It's an antiretroviral like the other medications, but in a different class. And it's one shot every month. So first injection, month later, second injection, and it's every other month. So once you're on the every other month schedule, it's 6 injections per year. Next. And then the kind of new thing that's coming soon is there's another long-acting injectable called lenacapavir that is already approved for HIV treatment, but is in study for HIV prevention. And just study results have come out and show that it's very effective, and it's an injection every 6 months. So it's not available yet, but it will be there soon. So that's also exciting. Next slide. So I wanted to look at the different options a little bit to kind of compare and contrast, because there is some differences. So with tenofovir, FTC, or Truvada taken daily, this is really can be used in all populations. So cisgender men and transgender women, cisgender women, transgender men, and people who inject drugs. Whereas TDF, FTC used as the 211 demand is only in cisgender men and transgender women, as well as TAF, FTC, or Descovy if it's given orally. So those ones kind of are restricted in that way. And then with cabotegravir, the long-acting injection, that's been studied in cisgender men, transgender women, cisgender women, and transgender men. So I think it's important to kind of just keep those things in mind to know what might be an option for individuals. Next slide. When we look at other things like side effect and access and other issues, so with daily Truvada and actually Descovy, if you use it on demand, and also Descovy, They all can potentially have minor GI side effects and headache. So things like nausea, upset stomach, diarrhea. Usually it gets better when you use it longer if you're taking it daily. And so people kind of get used to it. And it seems to be less also with people who are taking it on demand because they're just taking less pills. And both with both daily and on-demand Truvada, they're accessible now through generics, and so it's often cheaper. But one thing to note is that you can't use it with renal insufficiency. So if your creatinine clearance is less than 60, for TAF, FTC, or Descovy, again, the GI side effects, but it's also been associated with some a small amount of weight gain and some minor dyslipidemia as well. And this one you can use with some renal insufficiency, but not without a creatinine clearance less than 30. And with cabotegravir, by far the most common side effect is injection site reaction. So pain, redness, swelling at the site of injection. People usually, it gets better over time. So that's a plus, but it is something that's important to realize. Also with cabotegravir, there is significant access and infrastructure issues, really because of the work to get insurance approval often. And also your clinic has to have the infrastructure to be able to schedule the appointments for injections, have staff to give the injections, and also be able to track if people are able to if they miss the appointments, they get rescheduled for another appointment. Next slide. So for monitoring on therapy, all of them need obviously HIV screening. And so this is a little bit of a gray area, to be honest. The guidelines right now say that HIV antigen and antibody testing with PCR testing should be done at follow-up for HIV screening. And this was because of some new findings from the study actually that looked at cabotegravir, but also oral agents were used as a comparator. And so it's a gray area because some people feel that maybe just antibody antigen screening may be sufficient, but the guidelines say this, so that's what I'm going to include. And so it's antibody and antigen screening with PCR testing. One of the reasons is because PCR testing is the most sensitive test to diagnose, to pick up HIV, and especially with long-acting agents. It looks like those tests can become positive later because of the long-acting nature of the medication. With the testing for people who are on cabotegravir, remember that their appointments for injections are going to be every other month. And so what I found practical is that you do the testing at the first injection and the second injection, and just do it every 4 months every other month for the injections that they get then. That's an error there. Because it's hard to get people in for labs and then do the injection. It's just better, I think, to get it at the same time. For STI testing in general, for MSM, or men who have sex with men, and transgender women, we do it every 6 months. And as Dr. McNulty said, make sure that you're doing site-specific testing. And then for cabotegravir, we do the STI testing every 4 months. Again, with the creatinine, that needs to be monitored for the tenofovir, both formulations. With the TDF daily prep, it depends on if you're over 50 or a creatinine clearance is less than 60. But in general, for the other two, it's every 6 months, and you don't need to do renal function testing for cabotegravir. And for the TAF FTC, there is a recommendation every year to do lipids, whereas that's not the case for the other agents. Next slide. So baseline lab evaluation. So you need to assess for every patient for signs of acute HIV infection. So these are things like sore throat, fevers, chills, rashes that are kind of not for another reason, muscle aches, things like that. Next. And again, remember HIV testing, antigen antibody testing, and HIV PCR, especially if they have a history of PrEP use in the last 6 months, or really any type of long-acting, if they've ever had basically cabotegravir before for PrEP. And then STI screening, again, remember site-specific for gonorrhea and chlamydia, and remember, don't forget about syphilis. Next. And then if you're considering TDF or both of the tenofovir-based regimens, renal function. Next. and hepatitis A antigen or antibody testing, because remember that some of the populations really should be vaccinated for hepatitis A, so that you can assess that by doing this. And next. And then hepatitis B testing, remember to do the full testing, so surface antigen, surface antibody, and core antibody. The reason for this is that the tenofovir-based regimens actually treat hepatitis B, and so you may be unknowingly treating it, but then when you stop it, or if they're getting, if you stop it, then their hepatitis B can flare, and you shouldn't be using on-demand PrEP for people who have hepatitis B. So it's both to screen for hepatitis B, but also then remember that most of the individuals on PrEP should also be vaccinated, pretty much all, for hepatitis B, so you're also assessing their vaccination status. Next. So as was kind of highlighted by Dr. McNulty, I think we need to think of PrEP as part of a sexual health toolbox. So there's going to be a lot of, you can kind of slowly go through these and then I'll talk as you go, I think. So we first have HIV PrEP and PEP medications that are there. We also have testing, so HIV testing and also STI testing. Condoms are still there. They may not work for everybody, but it's important to talk to people and have them available for them. Hepatitis A, B, and HPV vaccination, and then DoxyPEP. So we talked about that. So yes, so we have to think about this as kind of comprehensive services, as was mentioned. Next slide. So some best practices, remember that we were doing routine screening for everybody 16 to 18 to 65. And more frequently based on indications. So we should be talking to our patients about routine screening. And the guidelines now are that we should be discussing PrEP, HIV PrEP, for all sexually active people. So we really need to be having this conversation with everybody. And the other thing we really need to do is link every negative HIV test with a conversation about PrEP. So often I think the old kind of thought is like, okay, you get an HIV test, it's negative, we're done. We got the test done, it's negative, we don't need to do anything. What we really need to be thinking about is, why was that person tested? Why did they want to get tested? And maybe we should be talking about HIV PrEP for them as an option. So I think that's really important. So where are the gaps with PrEP? What are the issues? Next. So we know the science is there. We know that it works. But we're not getting to everybody. Not everybody's benefiting from that science. And it's mostly because of access and receiving services, people being able to receive services who will benefit. Next. So there's definitely health system and provider barriers. So one thing that I really like to push back on is this idea that HIV PrEP is an ID issue, or infectious disease issue, specialty issue. So ID specialists are the only people that can do this. No, that's not the case. There's lots of ways to think about PrEP broader, and there's guidelines to be able to help people implement that and learn about it. So making sure that in every place that you're doing accessing patients, so it might be primary care, OBGYN, even urgent care and emergency departments, we need to be thinking about how we can get information and services about PrEP. Next. And we need to kind of break free from these traditional models of care for PrEP. So thinking about all points of care like the ED or even inpatient settings, teleprep, mobile services, and how to really integrate it into community-based and community-informed models of providing PrEP in places where people will benefit. Next. I think one of the roots is there's still a lot of stigma and reluctance about discussing sex and HIV testing, and some of that comes from us. And some of it comes from the community and patients, but we really need to kind of get over that and learn how to take inclusive sexual histories and talk about it in a way people are comfortable. Another challenge is we don't have a national system to support PrEP. So across the country, that's a real challenge for access. There's still some insurance barriers sometimes. Sometimes there's high copays or medication non-coverage. And there are real logistic implementations for long-acting PrEP in clinics. So coordination of the insurance benefits and pharmacy benefits, and then the staff resources for administration and coordination and follow-up. Next. So I wanted to just end with some resources because I think that these are really helpful for people who want to learn more. So on the left-hand side is the National HIV PrEP curriculum. So this is a curriculum created for really all healthcare providers. So physicians, APPs, nurses, even other staff in our clinics to learn about PrEP. It's free. And it's a very good general overview, and it gets updated a lot. So as things evolve with PrEP, it's a really great educational tool. And then on the right is the National Clinician Consultation Center. So this is a support for people who don't really necessarily have access to ID people, for instance, about like situations where you're not sure what to do, you have ambiguous test results, or you're not sure what to provide or what to do, and you can submit these cases both online and also through the phone. And so it's a really great way for clinicians to be supported when they have challenging cases to know what to do. And I think both of these are really, really great resources to support people in kind of being able to increase their practice of PrEP and providing PrEP for their patients. Next slide. And so if anybody has any questions, I'm happy to take it at the end, and then I'm happy to get any emails if anybody has any other questions. Thank you.
Okay, thank you so much. I will close us up. With some resources. Second, sorry. Okay, sorry about that. 1 second.
There was one thing I just wanted to mention to everybody. I realized when I downloaded the version, there's a few minor errors, I think, on some of the slides, and I can revise those very quickly so that when you're posting them or sending them out, they're the corrected slides.
That would be great. Okay, let me now share. Okay, so for the last few minutes, hopefully you can see my slides. Okay, so I want to just go, I know we just have a couple of minutes and then we will answer questions, or we'll answer the questions later. The primary IDPH resources are many. There is Title 10 and the recent expansion of Medicaid that is state and federal combined funds to help low and no-cost family planning services. This is on our website. Variety of locations throughout the state. And there's, again, you'll get these slides. So there's a federal way to find these family planning clinics by zip code. I am a massive fan of expedited partner therapy. We need to be offering it to anyone we diagnose with an STI. It is legal. You are protected to provide treatment for the partner of your patient with an STI. This is on the website because I've often been asked exactly how to write for expedited partner therapy, and worked with our great pharmacists in the state for what the best way to write these scripts is. There's fact sheets on our website. The perinatal syphilis warm line is a resource for syphilis diagnosis and treatment in the perinatal period. So pregnant, postpartum women and infants in the nursery. The warm line is sort of a curbside. Think of it like a curbside with maternal fetal medicine, adult and peds ID. This is for clinicians to call to describe your patient's story, to get help with getting public health record searches, to know their past syphilis testing and treatment, help with reporting, any resources that come about home treatment for bicillin for syphilis, with bicillin for syphilis, etc., will be sort of coordinated through the warm line. A warm line is different from a hotline because the calls are answered in a day instead of immediately. We have new reporting forms. Again, when you get these slides, you'll see it. This is for perinatal syphilis reporting for clinicians to report to get faster linkage to local health department resources. That's downstate, outside of Chicago. This is how to report syphilis and pregnancy within Chicago. And don't forget, I've learned a lot when I've been at IDPH, and one of the things is that it's a team effort, and there's STI teams in every local health department, and they are extremely knowledgeable and are there to help if your patient moves, need help with partner treatment, etc. So again, you will get these QR codes when you get the slides. The one on the left is to sign up for a listserv for those who provide OBGYN, women's health, and the right is a general resource guide for providers. And next in Fast Facts in December, Marburg, other special pathogens will be discussed, and in January, occupational and environmental exposures. This is the QR code to link to a way to reach out to the medical services division at IDPH with anything you think we can help you with. Happy to do our best. So that's a way to link to the form with any concerns. Whoops. This is the siren notification. Many of you probably already get this. This is IDPH's reporting notification for all sorts of things. And you can sign up and say your interest to get one specific to the work that you do. And this is our QR code to get the CME. All right, and I will stop sharing and see if there's any questions. Kaital put some, yeah.
We also have our program staff, Danny Brichavana and Michelle Ferguson, both from STI and our HIV PrEP divisions, to help answer questions, especially about PrEP for Illinois. Remember, it's free. Most people qualify for it. Don't forget EPT. And again, lots of resources for our providers to tap into. All right, there's also a survey link that's in the chat. Again, David, I don't know if you could put one more link just to refresh that link for people. And that's for the CME. I think we'll also intermittently try to get more feedback from the group on how you'd like us, what topics are of interest to you. And again, if there are topics of interest for you that you want to learn more about, let us know. Put it in the chat, put it in the Q&A. We'll be happy to get to them. And again, next is going to be, we've had a couple of Lhasa and Marburg outbreak concerns, I would say, recently, and we want our clinician community to be prepared on those. Again, survey link again in the chat. And we're at the hour. Thank you, everyone. We will send out the slides. We just need to tweak some of them, and then we'll send them out next week. And happy Thanksgiving. We'll see you in December.
Yes. Bye. Thanks, everyone. Thanks, speakers.
Thank you.